Welcome again to the fourth webinar of the series, Favorite 5 Days 5, reaching the finale of infertility treatment every Tuesday, an initiative of Rewari Obs Gyn Society. Today's topic is Infertility and Ovary, the Riddle Unanswered, on behalf of Jacksonpal Pharmaceuticals Limited, makers of Endorec tablet containing Dynogest 2 mg, injection Gonadorec containing leuprolide acetate 3.75 mg, and Lycorate Prex sachet with L-arginine, DHA, and lycopene. I am Dr. Vipin Tyagi, along with my teammates, Dr. Deepika Chabra and Mr. Amit Saxena. Thank you, Dr. Seema Mittal, President, Rewari Obs Gyn Society. She is the convener and moderator for this ICOG accredited webinar series, supported by Lalita Memorial Hospital Infertility Center, Rewari. To enlighten us on this topic, we welcome the scholars of the day, Dr. Himanshu Bavishi, founder Bavishi Fertility Institutes, Ahmedabad, Mumbai, Delhi, Kolkata, Surat, Vadodara, and Bhuj. Dr. Sanjay Makwana, Director, Vasundhara Hospital Limited, Jodhpur, Jaipur. Chairperson, Rajasthan, ISAR. We thank all the esteemed chairpersons for sparing your valuable time to impart words of wisdom to all. Dr. Uma Pandey, Professor BHU, President Varanasi Obs Gyn Society. Dr. Reema Goyal, Consultant Gynae and Infertility Specialist, Director, Vaishnavi Nursing Home, Gurugram. Dr. Meenakshi Bakde, Consultant Gynae, Shivanand Hospital, Umred District, Nagpur. And Dr. Kusum Lata Meena, Senior Professor and Unit Head, SMS Medical College, Jaipur. In the panel we have Dr. Alok Sharma, Assistant Professor Dr. Rajendra Prasad, GMC Tanda Kangra, Founder Secretary IFS HP Chapter, Dr. Harinder Kaur Oberoi, Consultant Obs Gynae Infertility Specialist, Director Oberoi Hospital and IVF Center, Jamshedpur, IFS Chapter Secretary Punjab, Dr. Ritu Dargan, Consultant Obs Gynae Director, Integra Specialty Clinics, Kamla, Nagpur, and as expert panelist, Dr. Dipankar Banerjee, Director and IVF Consultant, Ideal Fertility IVF and Genetics Center, Jabalpur. Welcome all attendees. Please make note, this session is streaming on Facebook Live. The recording will remain on our YouTube channel for reference and knowledge sharing. This series is brought to you by Jacksonpal Medical Services. We request all to please post your queries by text in the Q&A box, which will be answered at the end of the session. I will now request Dr. Seema Mittal ma'am to kindly initiate the session. Ma'am.
Hello everybody, on behalf of Rewari Obs Gyn Society, I welcome all my speakers, delegates, panelists and the chairpersons. It was my deep desire to meet Dr. Himanshu Bavishi and Dr. Sanjay Makwana, and I'm really happy that the dream has come true. And if we talk of the topics for today, so when we talk of ovary, it remains a riddle forever. But with expert speakers and the panelists, sure we are going to solve it in the end. And first we talk of endometriosis. Endometriosis as a clinical entity, it has been recognized and intensely investigated for more than a century. And still the uncertainty is there. We are not sure about the etiology. We are not sure about the clinical consequences and the treatment modality. Innovative surgical medical management has changed the treatment for patients, and definitely ART has a role, but still whenever there is a patient, there is a question mark how to go about it. Shall I put on medical therapy? Because when you are treating infertility, you are just treating infertility, and when you're treating endometriosis, you're only treating endometriosis. So to solve this dilemma, we have the most wonderful speaker with us, and we are proud to have with us Dr. Himanshu Bavishi, the director from Bavishi Institute and Infertility Center, and I will request Dr. Uma Pandey. Dr. Uma Pandey is Professor Gynae Obs from the most prestigious BHU, and she, besides her charming personality, she has so much responsibility. She has got so many publications all around, and she's chaired so many sessions and a very active Foxy member. In fact, I came to know her through the Foxy profile, and I was really impressed. I wanted to know more about Dr. Uma Pandey. So over to you, Dr. Uma, and thank you for being with us.
Thank you very much, Madam Seema, ma'am. Thank you. It's so kind of you to say that. I don't do much. I work in BHU, that is true, and there's lots of work, but that's fine, I think. I would like to thank you for inviting me. And also I would like to welcome Dr. Himanshu and Dr. Sanjay, and my co-panelists, Dr. Reema, Dr. Meenakshi, and Dr. Kusum. Dr. Bavishi, he was with us in Varanasi, and I have heard his lecture recently. And he has the best IMA award, excellence in the field of medicine. And he has done the first childbirth of India with vitrified frozen oocyte. He has written comprehensive book on a practical guide to intrauterine insemination. And he has organized many programs, including IVF Babies Meet in 2004. And he was founder president of INSTAR, which is Indian Society for the Third Party Assisted Reproductive Techniques. Without taking much time, I would request Dr. Bavishi to start his lecture. Thank you, sir.
Good evening and good evening, Dr. Seema Mittal. पहले तो मैं कह देता कि आपने पुकारा और हम चले आए, but unfortunately with this situation there is a difference. But fortunately with the help of technology, still we can do this, and that probably is really the way forward in any science and medical science as well. Technology has made a lot of differences so far as the management of any medical fraternity or any medical problem is concerned. Still, I would say that a lot of things are done in endometriosis as well, and still we need to do a lot of things. Why I am telling you that? Of course, I'll focus more on fertility aspect of endometriosis, but before we go for that, we need to understand that what it is, just the basic. Earlier, it was believed that it is a disease of only upper class white women, and it was just like presence of endometrial tissue and inflammatory reaction. And the word came from the Greek word inside the womb. But now we know that it is no longer a disease of upper class, no longer a disease of whites or anything. It is found in any women of reproductive age group, of any ethnic or social group. So it is much commoner than probably we thought. The only difference is that the awareness is increasing. So far as the etiology is concerned, again, we are just scratching the surface. The sites, of course, the commonest site is pelvic cavity, the peritoneum, ovaries, uterosacral ligaments. Other sites may be vagina, bowel, bladder, and ureters. And uncommon sites may be lung and brain, but scar endometriosis also needs to be considered, even not in patients of previous endometriosis, in the sense that so many times we feel that the scar endometriosis can be there in the patients who had endometriosis. No, even in a patient who was operated for cesarean section or myomectomy or anything else, or even hysterectomies, those patients also can have scar endometriosis, because that endometrium also can get implanted, and even, of course, the episiotomy scar endometriosis. This is the commonest picture which we all know, that where is the site, and the commonest site you can see here is the uterus and the pelvis, and then comes the ovaries and then the other sites. Now, etiology wise, as I said, that the original etiology was Samson theory, the retrograde menstruation. But you must have seen that whenever you operated a patient who is in period, and you can see that some amount of menstrual blood is going through the fallopian tubes inside the peritoneal cavity, and still every patient does not get endometriosis. So this is which was not very much convincing. And because we really, even today, do not know what the exact cause is, we have multiple theories of etiology: direct implantation of endometrial cell, metaplasia of coelomic epithelium, lymphatic dissemination, hematological spread, activation of embryonic cells rest, metaplasia of urothelium, hereditary factors. Of course, this is one of the important factors, but we still don't know how exactly it works, and immunological factors. So unfortunately, we really don't know why a patient gets endometriosis. And that is where it is one of the most difficult answer to be given to the patient, that why she got endometriosis. Because the first answer the patient asks is, "Ke doctor, mujhe kyun hua? Why I am suffering from this disease?" The prevalence wise, again, the symptoms are again mixed symptoms. So we don't have a fixed symptom as to what the patient is going to get. Like most common is pelvic pain and dysmenorrhea. And then comes the infertility. The endometriosis prevalence in the patients of infertility is 10 times higher than the fertile women. So that means there is a direct relation between endometriosis and infertility. Though we may not be able to stamp it or prove it definitely, or we cannot even sometimes say that what actually is causing infertility in the patient who has endometriosis. Now, risk factor wise, if you see that some of the patients have increased rate, like exposure to endometrial material because of the short menstrual cycle, heavy or longer bleeding, early menarche, late menopause, these patients get higher exposure to endometrial tissue in the peritoneal cavity. Family history and low exercise. This is again, we are finding this cause everywhere, more and more common, that the lifestyle is one of the factors, but how actually it affects, we really don't know. Whereas these are the factors which reduce the risk is number of live births and long duration of lactation. This is the main important thing which we need to counsel to our patients. So when a patient of endometriosis comes to you, the first thing which I counsel to my patients is that, look, by treating your fertility, you have two advantages. One, obviously you want a child and you will get a child, so that's very important. But at the same time, because of the pregnancy, because of the lactation, you will have a very long remission period on endometriosis, and that long suppression will give you disease-free period for even much longer time, which will be physiological. So if a patient of endometriosis understands the advantage of getting pregnancy is double for her, rather than wasting time in treatment if she gets pregnancy, it helps her, then it can become easier for you to convince the patient to go for fertility treatment. Symptomatology, as I already said, that it depends on the location, that's the most important. Then, of course, depends on the severity. So dysmenorrhea, dyspareunia, chronic pelvic pain, sciatica, premenstrual spotting, etc. If it is a gastrointestinal involvement, then the patients may have constipation, diarrhea, dyschezia, tenesmus, hematochezia, etc. And if it is involving the urinary system, then flank pain, back pain, abdominal pain, urgency, frequency, or hematuria. If, of course, it's pulmonary, then hemoptysis, ketamine, and pneumothorax. The most difficult part is that the significant proportion of the patients are asymptomatic. And that is where we even don't suspect them to have endometriosis. And when we do a laparoscopy for infertility, we find that the patient had endometriosis. Diagnosis based on symptom alone can be difficult because of the variability of symptoms, and there can be similar symptoms with many other conditions like irritable bowel syndrome, urinary tract infection, pelvic inflammatory diseases, etc. As I said, the dysmenorrhea is most common. Dyspareunia is very common if the patient has rectovaginal endometriosis. So if the patient has that complaint, then rectovaginal endometriosis must be suspected. And though whether you are doing a routine per vaginal exam, because many of the people have now stopped doing PV examination, they do PS and then do straight away a transvaginal sonography. But when you suspect involvement of endometriosis, the vagina or rectovaginal endometriosis, it is a very good idea to do a palpation, that's a PV examination, and try to find for the nodularities and nodules. So many times the symptoms do not have relation between stage and site of the disease. And normal clinical examination does not rule out endometriosis. Then the final question comes that how do we diagnose? Now that is the biggest problem because we don't have any definite signs and symptoms. Of course, as I said, tender nodules, visible lesion of scar, endometriosis, yes. Non-mobile fixed uterus and adnexa is one of the very important points which I'll highlight little later as well. Then, of course, sonography is mainstay, but again, sonography, the milder lesions or smaller lesions or spreaded lesions cannot be diagnosed on sonography. MRI also has its own limitation. CA125 again is very non-specific, and that is where the major mainstay of diagnosis remains a laparoscopy or an accidental finding on a laparotomy, and confirmation, of course, by histopathology. So that is where it is very difficult that how would you do a confirmed diagnosis? Because would you like to subject your patient to laparoscopy just for the sake of diagnosing the endometriosis or not? Sonography, yes, if you have a chocolate cyst, then it is much easier to diagnose if it's maybe unilateral, bilateral, single or multiple. So it may have regular or irregular shape. It may be mobile also. Always may not have a very classical look of what we call as ground glass-like appearance, and the vascularity is not increased compared to the malignant lesions if we are comparing. But when the chocolate cyst in the initial stages of development, you may not see the very classical ground glass appearance all around. You may see partial, you may not see it complete. And it may be difficult for you to differentiate between a corpus luteum and a chocolate cyst. And that is where it is very important for you to understand that when was it first diagnosed. So what we can do is that we can try to take a proper history, ask the patient that whether she went for a sonography earlier or not. And if there was a sonography earlier and if there was no cyst, that means it is probably a corpus luteum. But if the cyst is persistent for a longer time, then it can be a chocolate cyst. And by chance, if the history is not available and we are not in urgency of diagnosis, we keep a note of it and keep following the patient. What happens to the cyst, that may also give us a more detailed diagnosis. The sonography findings, the fixed uterus, retroverted uterus, mainly believed, but what is even more significant is antiverted retroflexed uterus. You see that the fundus of the uterus is just pulled like that because of the adhesions in the pelvis. Ovaries and adnexs are close to the uterus, chocolate cystiomas, adenomyosis, adenomyomas, and probe tenderness. These are the signs which can help you that this patient may have endometriosis. Now, this is a typical uterus, which I was trying to say that it is an antiverted uterus, but you can see that the fundus is pulled back. And this is very typical of the adhesions because of the endometriosis. This is one more picture, and you can see that the ovary is close to the uterus here. Again, one more patient. Again, you can see that the ovary is close to the patient. Again, similar kind of a situation. And one of the commonest thing, you find ovaries close to the uterus because of the adhesions of the ovary. You can see again here the ovaries are closer to the uterus, ovaries closer to the uterus. And you can see sometimes, even this is a picture which you can see in the post-operative patient, like a patient had a severe endometriosis, a corrective surgery is done, bilateral chocolate cysts are removed, and then you see after some time, you can see that both the ovaries, these are called kissing ovaries, or both the ovaries are stuck behind the uterus. Of course, sometimes you see this Mirena introduced inside the uterus. You can see an adenomyoma into the uterus. So these are the findings which can help you diagnose or sometimes suspect endometriosis. The CA125, as I said, is non-specific. So if it is more than 35, then yes, you may suspect. But these are the differential diagnosis which is difficult for you to make. MRI, again, as I said, sensitivity is around 80% and specificity around 95%. And these are the barriers, as we already discussed, that the unappreciable diagnosis, so many times on an average 7 to 12 years of delay is there before the diagnosis is done. So if an infertile patient comes to you, you always keep that in mind that she may have endometriosis, though it may not have been diagnosed. And it is most of the time mistaken as routine pain because of the nulliparity. Then comes the laparoscopy, the most important, because the diagnosis, confirmation of diagnosis, explaining to the patient that she has endometriosis, and then explaining the line of treatment definitely needs a specific diagnosis. And that is where laparoscopy helps us. Primary means of definitive diagnosis, clinically visualized findings may represent tip of the iceberg. So this again is important, that so many times you may see lesions, but there may be so many other lesions which are spread out but are not visible, and you may not be able to see that. So this also we need to explain to the patient. So many times I see even the consultants, they feel that I have done a great job, I have cleared everything, I have cured your endometriosis, yeah, now you don't need to worry. No, that is not the correct thing. We cannot cure the endometriosis. We can correct to the whatever best extent we can see it. So what we better explain to our patient is that we can see only the lesions which have erupted or which are visible. There are so many non-erupted or non-developed lesions may be lying, and they may remain untreated, because you can't keep on doing fulguration all around without finding the definite lesion. Accuracy of diagnosis depends on ability of surgeon as well, you know. So it can, because it can look like vesicles, flat packs, raised blebs, polypoidal structure, area of fibrosis, adhesion, peritoneal defects, and color of the lesion again may be yellow, brown, blue, black, red, and gray. So you can see these classical pictures. This again is a very classical picture, very localized, but still a classical picture. You can see certain blebs like these. This is of course a very typical picture which we can see, and so many presentations. Only solitary lesions like these also are quite often seen. So then how do we explain to the patient that what is the severity of her disease and what should be the line of treatment or prognosis explained to the patient? So for that understanding, classification of ASR, and this you all know, it's a busy slide, but just for your reference, that this is still a very important classification. And this is the nutshell of that classification, that if the staging 1, 2, 3, and 4, depending on the points, small superficial lesions, etc., small to medium implants, large widespread implants, and large implants of endometrioma, extensive scar tissue, etc. So depending on that, we can tell them either stage 1, 2, 3, or 4, or minimal, mild, moderate, or severe endometriosis. The advantages of laparoscopy are very obvious. That it's a gold standard investigation and possible to diagnose and treat at the same time. So another take-home message here would be that whenever you are doing a diagnostic laparoscopy, you always should be prepared to do the treatment at the same time. So patient does not have to go for the treatment, I mean the scopy, that is an operative treatment again. You have to be prepared that there may be mild, of course, if it is a very bad case, you know it earlier as well. But if you come across, you know, some kind of adhesions or lesions or something, you should be able to handle it. The disadvantage of laparoscopy is very obvious, that it requires a facility and surgical expertise. Not suitable patient or acceptance is again so many times a problem. There can be false positive and false negative finding even on laparoscopy, and it is of course a surgery which has its own risk as well. Now coming specifically to infertility, we have still not understood that why endometriosis causes infertility. As I said, that it is 10 times more common in infertile population than in fertile population, but at the same time, we don't know why it causes infertility. There can be, of course, very obvious reasons like mechanical interference, like pelvic adhesions, chronic salpingitis, altered tubal motility, distortion of tubo-ovarian relationship, or impaired ovum pickup by the fallopian tube. Or it can be because of increased concentration of prostaglandins, increased number of activated macrophages, increased production of cytokines, or enhanced phagocytosis of the sperm. It can be because of the immune response as well, like increased cell-mediated gamete injury, increased prevalence of autoantibodies, or anti-endometrial antibody production. It can also be because of the hormonal causes like defective folliculogenesis, luteinized unruptured follicle syndrome, hyperprolactinemia, luteal phase deficiency, etc. And in IVF, when we do, there can be fertilization or implantation failure, which is little higher in this group of patients, and early spontaneous miscarriages as well. Now, before we explain to the patient, we need to explain these things also, that it is a generally progressive disease. The regression may be there, but not always. So many times it may regress to some extent as well. Recurrence rate is very high even after the treatment, may be surgical or medical. And regression may be spontaneous, of course, but it is uncommon. But as I told you in the earlier part of my presentation as well, that the pregnancy is one of the very important regression therapy as well. And of course, we now have medical therapy choices as well. So when we are discussing the treatment options with the patient, what are we offering? One, of course, is the expectant management. Now, expectant management is a good option in the sense that if it's a case of mild endometriosis and other things are favorable, that also is very important. So many times it happens that we are, focusing only on one particular aspect of the disease. Like so many times the male infertility or female infertility disease like endometriosis, we focus only on endometriosis. No. Because it's the overall fertility, not only of one partner, but of the couple is important. So we need to take into consideration all other aspects apart from the disease which we are seeing. So age of the patient, duration of marriage, what treatment she has already tried, what are the other factors which may be affecting the patient, what is the male partner situation, etc. And then we, of course, if rest of the things are favorable, then we can have expectant management. But there also we need to explain to the patient advantages and disadvantages. NSAIDs, of course, are good for pain relief, but they are not good to control the diseases. Oral contraceptive pills were used for a very long time to suppress the disease, but we all know that they are not allowing the patients to conceive. That is number one. And that is not our target when we are talking about the fertility. So they are not a good option at all for the patients who are thinking of fertility. So many times I see my colleagues saying that, okay, it's better that you take oral contraceptive pills for 3 months, 6 months, so that your endometriosis will be suppressed, and then you do fertility treatment. Now, this is not really a good idea unless she is willing to take the pain relief first and not willing to go for fertility treatment. Same thing will apply to aromatase inhibitor as well, that if your target is to suppress the pain or the disease, then yes, but that again is not helping in fertility. Progestogens in endometriosis treatment has remained again for a very long time because it inhibits pituitary LH, it growth promoting effect of estrogen on the endometrium, conversion of estrone rather than to estradiol. And we have been using medroxyprogesterone, norethistyrone, medroxyprogesterone depot injections, intrauterine levonorgestrel, and now fortunately we have Dynogest as well. And this, of course, is a little busy slide, but only what I would like to highlight here is that from one generation we have moved to second and third generation, and now fortunately we have fourth generation of progesterone, which is Dynogest or drospiridone. So these are the biggest advantage of this fourth generation of progesterone is the lesser side effect and better other profiles. So that helps us reduce the side effects of the progesterones for longer duration of use. And of course, we need to consider two, like based on the various effects they exhibit, two effects are very important. One is the progestational effect, how the progestin stimulates the progesterone receptor, thereby helping to prevent ovulation and lessen the menstrual bleeding. So that is one of the things which we have to consider. But at the same time, we have to consider the androgenic effect of the progesterone as well. So how much androgenic effect that particular progesterone is likely to have is also an important thing, like acne, hirsutism, deepening of voice, etc. And of course, the systemic side effect of carbohydrate metabolism as well. And that is where, as I said, the Dynogest has a place because it's a hybrid progesterone of fourth generation. So it has a much better safety profile even when it is used for a longer time. But at the same time, Dynogest is not a fertility promoting drug. So when the patient is on Dynogest, you can't do fertility treatment for the patient. So that is one of the most important things. The second thing is that, as I said, that of course there are so many times they say that you give Dynogest for 3 months or 6 months to the patient for suppressing the disease and then do the treatment. Now that as a routine is not an advisable thing because that wastes time for the patient. But of course, if the patient does not want to do the treatment for some time, or her symptoms are severe and wants to get suppression for some time, and even cases of adenomyosis where you want the adenomyosis to be suppressed for some time, then you have an option that you give the drug for 3 to 6 months and then do the treatment. This pharmacological effects, you all know that it has a no anti-estrogenic effect, no effect on metabolic or cardiovascular system, high efficiency and safety, and less adverse effects. So these are the advantages of Dynogest. And of course, the lipid metabolism and all is very less affected. So far as the long-term use is concerned, then also the safety profile is much better. And the symptomatic relief of patient after 3 to 6 months of use is also good. Of course, just to mention Danazol, now to me it is in a history. We don't use because of the lot of side effects it had. One of the real option is the GnRH analog depot preparations. They are still there and they are still being used by our colleagues as well. We have 1 month depot and we have 3 months depot. Both the depots are available and they are good for suppressing the endometriosis for the time. The only disadvantage is the trabecular bone mineral content reduction, vasomotor symptom because of the sudden menopause, and there can be low level of estrogen supplementation in this group of patients. Now here also I would like to highlight one very important point, that because so many times it happens that the consultants or the surgeons are not very confident of their own efficiency to clean the pelvis through laparoscopic surgery when the cases of stage 3, stage 4 endometriosis are there, or there is no sufficient removal of chocolate cyst, or whatever the reason, there is a tendency to give depot preparations after laparoscopic surgery. Now this really is not a good idea, because when you do a corrective surgery, that's the best time for patients to conceive. Don't waste that time, utilize that time to make the patient pregnant rather than wasting that best time by suppressing. The suppression will be good idea when you think that the patient needs suppression and you want to go for ART immediately after that. And in that case, yes, of course, you suppress and then straight away take the patients for ART. The mainstay of treatment is, of course, surgery. And surgery, again, we need to have a clear idea as to what are we planning at. Are we planning at pain relief? Then of course we do that way. But when we talk of fertility, then we need to keep everything in mind. A conservative approach is a must. Minimum damage to ovarian reserve, restoration of anatomy should be an important thing. And this is a correct word which I always love to use, as the tubal potency evaluation and augmentation. Patency in endometriosis, 99.9% is patent. So many times you see that the tubes are patent, that's perfect. But they may be kinked, they may be involved in adhesions, they may be having endometriosis lesion. So all these situations, if you try to restore the tubal potency, that really makes a difference. So patency versus potency is an important thing. And when we are thinking of fertility, potency of the tube is equally important. Of course, the deep infiltrating endometriosis requires special consideration, and depending on which location and what situation it is, you need to do it. But that definitely requires a very good skill and very good setup. Second look laparoscopy is usually not required, particularly in infertility patients. It is required only in the patients where you really have a doubt and you really want to, evaluate that whether you can do X, Y, or Z or not. But routine second look laparoscopy is not required in any of the patient. Post-surgery depot, I already told you. Recurrent surgery is again a very difficult thing. So more and more surgeries you do, the surgeries keep on becoming difficult. So it is not a good idea, particularly in the patients where fertility is the target. However, sometimes the symptoms of the patients are so bad, or the chocolate cysts are so bad, or the adhesions are so bad that you might have to do a recurrent surgery. But redo surgery again requires a lot of skill and capabilities of the surgeon to do it. And here again, you should have a clarity in mind that what actually you are going to achieve, because whatever best you do, the disease is going to stay there. So what you do is you try to minimize the operative intervention and achieve fertility. Pre-operative suppression is not a good idea for endometriosis, because then you will miss on so many lesions which otherwise you can see, and it does not help in the surgical skills, surgical procedure, even if it may be a disease or a chocolate cyst. Destructive surgery, of course, is not indicated so far as the infertility is concerned, but we have seen patients, very occasional, but in such a bad situation, their pain is so bad, it's totally intolerable for them, and then you have to do a destructive surgery also. But in that case, you do a fertility preservation. You either freeze the ovary, or you freeze the oocytes or the embryos before you do a destructive surgery. So far as the outcome of the treatment is concerned, the last aspect of the treatment which I like to discuss here is the ART. Of course, stage 1 and stage 2, there is hardly any difference so far as the outcome of ART is concerned in the patients of endometriosis. Stage 3 and 4 may have significant difference, like because of the poor ovarian response, poor ovarian reserve, technical difficulties in ovum pickup, and poor egg quality or poor pelvic environment. As I said earlier as well, that we don't know the exact cause of everything of this, but this is the experience which we have. However, so many studies claim that they get equal pregnancy rates even in severe endometriosis, whereas some studies claim that they don't have exactly the same success rate as in severe endometriosis. But one thing I would like to highlight here is that more and more consensus is going in favor of doing ART before doing a laparoscopic corrections of chocolate cyst removal, etc. Because when you remove the chocolate cyst or do an extensive surgery, you hamper the blood supply of the pelvis. You may remove some part of the normal ovarian tissue as well, and those collectively reduce the fertility potential of the patient. So it is better we do IVF, we take the eggs out, depending on the situation. If the patient is not willing to conceive, the symptoms are so bad, you can freeze the embryos and do the embryo transfer later. Or if that is not the case, you can do the embryo transfer routinely, just like any other patient, fresh or frozen, depending on the situation. Achieve the pregnancy. As I said, that it may give patient the disease-free period as well, and then depending on the situation, we can do. Whatever the big size of chocolate cyst and all, in my experience, I have been able to do ovum pickup in every patient. I have not done a single laparoscopic surgery just to make my ovum pickup possible. Because a stimulated ovary gives you a direction or a place from where you can go and get the follicles out. So, pre-operative excision of chocolate cyst, as I said, that there is no improvement in outcome, but it can reduce the ovarian reserve, so it is not a good idea at all. Any questions? Of course, we are going to take at the end of the second presentation. So for that, for time now, thank you very much for your opportunity and hearing, and the participants, I hope you enjoyed.
Thank you, sir. Thank you for such insightful presentation. And definitely, I agree with you. The diagnosis is delayed. We have so many young girls coming with ovarian cyst of different types now, and it becomes very difficult to say that this is hemorrhagic or this is endometriotic cyst. And spontaneous regression, I feel so we have actually not seen in any patient. I hope it happens, but we tell them once you conceive, it will regress spontaneously. And very precisely, you mentioned, sir, about the depot preparation after surgery, because I have seen some of my patients who were given depot preparations and they developed such severe postmenopausal symptoms, and they were restless, they had hot flashes, and it was really difficult to manage them, and they were amenorrheic for such a long time. So this is a very right take that we should not be giving any depot preparations. And so regarding this, there is one question we can take from Dr. Anu Gupta. She just mentioned that 19 years old girl had come with a cyst, and she has got abdominal pain, and this is hemorrhagic cyst on ultrasound. So should we give her diagnosis or OC pills? So
sorry, you asked me a question. Sorry.
yes, sir. Sir, there is a question from audience. One question, yes, sir.
Okay, can you please repeat that question?
Yes, sir. She says that is a 19 years old girl. This is from Dr. Anu Gupta. That patient is 19-year-old young girl who has come with abdominal pain. and ultrasound says this is hemorrhagic cyst. So should we give her diagnosis or OC pills?
Okay, OC pills will be still a better idea because she's already 19 years now, and hemorrhagic cyst is not necessarily a chocolate cyst. Right. Some of the people believe that you can give a diagnostic dose of or a course of Dynogest to the patient just to rule out whether the patient has endometriosis or not, because the Dynogest will suppress the symptoms of the. So that I don't think is a good option. So hemorrhagic cyst can be just symptomatically treated, and you can wait for some time. It should be fine.
So OC pills are the better option, right, sir? And there is another question from Dr. Koneru Gangadhar Rao. That scar endometriosis, can we give drug treatment before going for surgery?
There is absolutely no need, because it is not going to suppress. So if you just want to buy time because the patient is not prepared for surgery, then yes, you can. But the better idea is to remove. And drug treatment would be symptomatic rather than giving, because your target is only to relieve the patient of the symptom till the time you do the surgery. So there is no need to give something like Dynogest or something of that sort which suppresses the disease. You give something as a pain relief so that the patient is comfortable till the time she goes for surgery.
Thank you, sir. That was brilliant sharing. And over to Dr. Reema to thank sir for the wonderful presentation and sparing the valuable time. Dr. Reema Goyal is infertility expert from Vaishnavi Hospital, and she's our very active IFS executive, and she's always there with a helping hand whenever we need her. Over to you, Dr. Reema, to thank sir for this brilliant presentation.
First of all, I would like to thank Dr. Seema for a wonderful presentation series which have been going on in fertility. And I would like to thank Dr. Himanshu Bavishi sir for a wonderful presentation on endometriosis, clearing all our doubts in the mind regarding every aspect, like regarding the diagnosis, how to go ahead about it, interpreting the ultrasound pictures basically, which we as youngsters face difficulties, and thinking about the treatment options, telling the correct treatment options to our patient regarding the counseling of the patient, and yes, definitely the infertility scenarios nowadays, going for ART and how to improve our ART outcomes. So thank you so much, sir, and thank you for enlightening us on this very difficult topic of today's generation, because we as infertility specialists are more worried about our outcomes per se. We want success in our, all the IVF cycles, all the patients we are treating, we want them to be successful. But the only thing is that we should be very careful while going and approaching the ovaries in such patients, as these are very, they get adhered and to any of, like, it can be at the back of the uterus or in the at next cell, it can be very fixed ovaries. So we have to be very careful while doing the ovum pickups. So thank you so much. Over to Dr. Seema now for continuing the presentation further.
Thank you, Dr. Reema. Very rightly said. The much dreaded endometriosis was simplified in a wonderful way, sir. So, Himanshu sir, thank you so much. And now we shift to second topic, ovarian hyperstimulation. As we know, it is the gravest complication of ovulation induction. So there is ovarian enlargement, increase in ovarian hormones, and increase in all the vasoactive factors, not only hormones, and there is loss of fluid from third space, and definitely the one who suffers only knows. So we have the person who will definitely justify the topic and tell us how to prevent it, and if it happens, how to diagnose it and how to treat it. So we welcome Dr. Sanjay Makwana, and Dr. Sanjay Makwana will definitely solve the riddle, and I will request Dr. Kusumina is there, Dr. Kusumina, to introduce Dr. Sanjay Makwana sir. Wonderful profile that sir has. He's the director of Vasundhara Hospital and faculty member of so many societies, and has so many awards to his credit. Dr. Sanjay Makwana, he's done diploma in pelvic endoscopic surgery from Germany. He's ex-executive member IFS ISAR. He's the chairperson of Rajasthan ISAR. He has published 13 papers, chapters in 5 textbooks. And as we have invited, he's the faculty member at various international conferences and national conferences, because he's such a wonderful orator. And since 1995, he's working in the field of infertility and endoscopy. and he would justify and solve the riddle that we have around the ovary. Sometimes when the ovary is hyperstimulated, it is dreadful. Sometimes when it is not working, it is again a misery because we go into premature ovarian failure. And sometimes when it is dreading, there is ovarian malignancy. And in gynae, all of us just dread ovarian malignancy out of all the parts of our gynecological anatomy. And here we have Dr. Sanjay Makwana to speak on ovarian hyperstimulation, sir. Welcome, Sanjay, sir.
Thank you, Dr. Seema, and thanks to the Rewari Obs Gyn Society for inviting me to this exciting webinar, which you people are organizing regularly. And after Dr. Bavishi's excellent talk on endometriosis, I'll be talking on the ovarian hyperstimulation syndrome. And as you have put the topic in the way that who is the sufferer, would like to know more about the hyperstimulation. And I say they are the two people directly involved in the ovarian hyperstimulation. One is the patient, and second, the clinician, those who are stimulating the ovaries. So they too want to know more about the ovarian hyperstimulation syndrome and how to handle it. Let's see what the hyperstimulation is. We notice the hyperstimulation syndrome, which is iatrogenic complication of supraphysiological ovarian stimulation, is a totally iatrogenic complications, acute and reversible. The syndrome is almost exclusively associated with exogenous gonadotropin stimulation and is only rarely observed after clomiphene citrate or spontaneous ovulation. And we all are very well aware that the ovarian hyperstimulation is associated with the two major complications. One is the multiple births, and second is the ovarian hyperstimulation syndrome. And nobody wants to have the second complication in clinical side. The first and the foremost thing for us to understand is how to predict the ovarian hyperstimulation syndrome. And before that, we must understand the population at risk. It can be based on identifying the characteristic of a patient who would be the high responders. High responders are the population at risk. This can also be helped with the help of a sonography as well as the blood estradiol assessments. Ultrasound always plays a very important role in the ART practice or in the practice of ovarian hyperstimulation. It has a role before, during, and even after the ovarian stimulation. If we come to the incidence of the ovarian hyperstimulation syndrome, especially after the controlled ovarian hyperstimulation, it is found that 7.3% of the cases land up either as a mild to moderate, and 4.2% of the cases land up as a severe disease of ovarian hyperstimulation syndrome. Clinical picture, all people are aware, those who are dealing with ovarian hyperstimulation with the gonadotropins. The most commonly seen symptoms are the distension of lower abdomen, nausea and vomiting, dyspnea with respiratory distress, diarrhea, quick weight gain, reduced urine output, abdominal pain, and hyperproteinemia. One can classify the ovarian hyperstimulation syndrome into the two categories. One is the early ovarian hyperstimulation syndrome, another is the late ovarian hyperstimulation syndrome, that is based basically on the day of the SCG is given. The early days means 3 to 9 days can be labeled as the early ovarian hyperstimulation, and second is based basically through the pregnancy, that is between the 10 to 17 days of an injection SCG. So early ovarian hyperstimulation syndrome onset is within the 9 days of site retrieval, is recognized by the high estradiol level, where is high follicle number, possibly because of the exogenous SCG. In the case of late ovarian hyperstimulation syndrome, seen most of the time after 9 days of retrieval, associated with the multiple gestation, and mainly because of the endogenous SCG when pregnancy starts. We have to understand that the early ovarian hyperstimulation syndrome is more or less mild to moderate. Severe categories are very severe. In case of a late onset ovarian hyperstimulation syndrome, most of the time it is moderate or a severe variety. So it becomes very important to understand what type of the clinical picture this ovarian hyperstimulation syndrome can present to us. Mainly, it involves the pulmonary functions, especially associated with the dyspnea or pleural effusion, or in the severe conditions, the ARDS. Liver dysfunctions are seen in 25% of the cases, whereas the renal dysfunctions are seen with the oliguria, hyponatremia, hyperkalemia, acidosis, and as high as 30% of the patient. Thromboembolic phenomena are seen in 1 to 10% of the cases. In the very severe cases, one can see the mortality mainly because of the ARDS, cerebral infarction, or the renal failure. People have tried to grade the ovarian hyperstimulation syndrome. The grading which is most commonly used is the Golan et al. Given in 1989. It's based on the severity. This grading can be classified as a mild, moderate, and severe variety also. The grade 1 and grade 2 is mainly associated with the abdominal distension, nausea, and vomiting, and ovarian size is more or less between the 5 to 10 centimeter. Grade 3 and 4, which is labeled as the moderate variety of the ovarian hyperstimulation, where the ovarian size is 10 to 12 centimeter. Apart from the abdominal distension, nausea, vomiting, the one can have the fluid in the peritoneal cavity or in the thoracic cavity. The severe, where the grade 5 is included, it can have the 3 A, B, or C categories. A means there is a presence of the ascites, B means there is a deranged biochemical profile, and C means the patient is critical and requires the intensive management. So all these things can be summarized into the biochemical findings also, where associated with the severe electrolyte disorders, hyperproteinemias, rise in serum creatinine level, and the hypercoagulable states. How it starts? The pathophysiologically is basically associated with multiple follicle formations. That multiple follicle formation and the trigger by the HCG is responsible for increasing the level of VEGF. That can also increase the working of the IL-6 or IL-8 that leads to the angiogenic activities and the increase in the vascular permeability. This increase in the vascular permeability is responsible for the fluid extravasation in the all cavities, especially the thoracic cavity or a peritoneal cavity, and lead to the severe hyperproteinemia. So for us, it's most important to predict the ovarian hyperstimulation syndrome and to avoid the complication of it. This can be done pre-treatment also. We know that the polycystic ovarian patients, the patients with the increase in antral follicle counts, patient of a young age, and the history of the ovarian hyperstimulation syndrome and the previous stimulation are the typical patient may end up in ovarian hyperstimulations. It can be recognized during the ovarian response also with the high estradiol levels. There's a high number of the follicle growing, or if we put the power Doppler with the low intra-ovarian vascular resistance, even at the time of the pickup, the number of eggs can also help us in recognizing the incidence, or we can predict the ovarian hyperstimulation. But there is no agreement on the cutoff level that how many number of eggs or the follicle are really going to land up us in the hyperstimulation. But the widely used in practice, and they have the very poorly predictive values, especially in case of a late ovarian hyperstimulation syndrome. At least 1 in 3, the severe OHSS are missed by the commonly used criteria of ovarian response, and therefore we have to really be careful in selecting the patients or predicting the ovarian hyperstimulation syndrome. What is the relation between the PCOS and the ovarian hyperstimulation? Most of the time we consider that the PCOS patients are the patients going to land up in ovarian hyperstimulation during the gonadotropin stimulation. Yes, most of the studies is found that the 37 to 63% of the patients from the PCOS group will have the higher chances of ovarian hyperstimulation than the control group of the patients. What is the relationship between the age and ovarian hyperstimulation? Again, it is found that the younger the patient, the more chances of having the hyperstimulation, especially beyond the age of 30, the chances of ovarian hyperstimulation will reduce. Maybe it's associated with a lower FSH, one can say, or is you can say the ovarian makeup or the ovarian reserve, whatever is responsible. But the younger patients are more exposed to the ovarian hyperstimulation. Is there any relation of a genetic predisposition to predict the ovarian hyperstimulation syndrome? Especially the mutation in the FSH receptors that is responsible. There are the two types of the receptor. So one is active and another inactive receptors. The active receptors are more associated with the ovarian hyperstimulation, and inactivity in the mutation of the FSH receptors is basically related with its infertility. Can we put the AMH also as a predictor of ovarian hyperstimulation syndrome? If we put the AMH, age, and the BMI together, then the specificity and the sensitivity, all these markers will increase, and we can have the really very high prediction for the ovarian hyperstimulation syndrome during the stimulation with the gonadotropins. The serum VEGF, as always talked about as the major culprit for the OHSS, can it be used as a predictor of ovarian hyperstimulation syndrome? Basically, it's a pathogenic agent, and levels are found high in the OHSS cycle. But as a marker, has a less predictive value rather than it's a ovarian response marker. So it cannot be used as a marker till we have the more studies in our favor. Antral follicle count can predict the hyperresponders, and it can also have the higher accuracy to predict the ovarian hyperstimulation syndrome. If the one is getting more than 16 of the antral follicle counts, definitely the accuracy of predicting the ovarian hyperstimulation syndrome is going to be very high. Can the perifollicular blood flow, especially putting the Doppler during the ovarian stimulation, can help us in predicting the ovarian hyperstimulation? Yes, the intra-ovarian low resistance vascular flow can give us some idea that this patient is going to have the much higher response than the normal patient, and through this we can really predict the ovarian hyperstimulation syndrome. So coming to the prevention of ovarian hyperstimulation syndrome, and this can be done first by predicting the ovarian hyperstimulation syndrome, and second, we have the two types of the prevention. Either the primary prevention, which can start before giving the gonadotropins, or secondary prevention, which starts after giving the gonadotropins before giving the trigger with the HCG. Let's see what are the options can be. The prediction can be best by predicting the characteristic of the patients. Good predictors are the where you have the PCOS, young age, high antral follicle count, E2 level on the day of HCG, insulin resistance, ovarian volume, AMH, all these, they can help us in having the better idea about the ovarian hyperstimulation. As far as the bad predictors are considered, they are the genetic predispositions, the serum VEGF levels, or the perifollicular blood flow. They can be because they are too late to predict, so they are not considered as the good predictors. They are the patterns which require more workup, include the PCO type of the ovaries, BMI or day 3 FSH. They are still not very dependable. So primary prevention. The primary prevention basically is before starting gonadotropins, and there are the following approaches one can consider to decrease the incidence of ovarian hyperstimulation in the clinical setting, and they are considered as level A. You can say the criteria for the safety profile, especially when we use FSH compared to HMG in the stimulation as the more safety profile. A step up compared to the conventional protocol for IVF. This is a better, or you can say the favorable answer. Use of antagonists compared to agonists, of course, is considered to have the lower amount of the follicle going for a growth, or you can say for the maturation, so has the better predictions. IVM compared to the IVF, but is associated with a low birth rate, so it's not considered to be a good marker. Sequential compared to the step-down protocol is still not very dependable. The following approaches are equivocal, especially when it comes to the primary prevention of ovarian hyperstimulation. The alternate day compared to the daily or the conventional protocol, the sequential compared to the step-up protocols. But there is an approach that is the step-up when we compare to the step-down protocol, it still require further workup in the IVF protocols. Late prevention, when we have already started the gonadotropins and before the HCG, now we are thinking about the hyperstimulation. Can we prevent it? There are a lot of options available. Few of them are really dependable. Few of them are still under the early stage of the workup, and they require more robust data in our favor. Then and then they get used. The options available to us is it starts with the cancellation of the cycle, then the posting by decreasing the HCG dose, use of agonists as a trigger, metformin, albumin, capacolin, calcium gluconate injections, cryopreservation of embryos, use of agonists with embryo freezing, unilateral follicular aspiration before the HCG trigger, or the laparoscopic ovarian electrocautery before starting the gonadotropins. So these are all options, but a few of them are really very good, and they can help us in preventing the late or the early onset of the ovarian hyperstimulation syndrome. Let's come to the most talked about option available to us is the posting. Posting can start. We know that the estrogen production in the dominant follicle of more than 16 millimeters is more than 150 picogram per follicle, and when the level goes beyond 4,500 picogram per ml, or the numbers are more than 15, they can be considered for the posting. For the posting, you require a lab in-house which can give the estrogen concentration every day. And when you are withholding the gonadotropin doses for 3 to 4 days, the estrogen level will fall down to 3,500 picogram per ml. And this is the time when one can give the HCG trigger and go ahead with the ovum aspiration. But if the level rises to 6,500, or they are more than 30 follicles, or posting is taking more than 4 days, then it's better to cancel the cycle because the posting is not going to work in these patients. These are pictorial presentations where you can continue with the agonist cycle. This picture is basically when we used to have the long protocol and agonist cycles. Same can we have with the antagonist cycle also. You can continue with your antagonist. You can check the gonadotropin doses for 3 to 4 days till the level of estradiol comes down or close to 3,000. Then at that time you can add the HCG. But that posting should start when you have the number of follicles around 15 and they are close to the size of 16 millimeter. In one of the surveys which was published in Human Reproduction 2001, out of the 573 HRA members, the 60% of the members of that survey has used the posting to prevent the hyperstimulation syndrome. FSH deprivation may allow the smaller follicle to undergo the apoptosis. Basically, we know that the smaller follicle or the medium-sized follicle are more dependent on the gonadotropins from the outside. And the larger follicle, now they are already mature, they doesn't require gonadotropin for their survival, and their own estrogen will continue to keep them alive or keep them survived. So therefore, the smaller follicle, which are dependent from the outside, their growth can be checked when you are going for the posting. There is indirect evidences that suggest the lower VEGF follicular fluid level after the posting, and that is probably in the favor. One must understand because nowadays we are using more of the antagonist cycle. In the antagonist cycle, there can have the surrogate marker because of the low number of the follicles and the less amount of the estrogen is produced. So that can have the masking effect, and still we have the effect of the ovarian hyperstimulation syndrome. In case of antagonist versus the agonist, which cycle is to be preferred? The lower oocyte number and the estradiol concentration may be used as a surrogate marker of a low risk of ovarian hyperstimulation. There is another study, or you can see the Cochrane meta-analysis showed a reduced incidence of ovarian hyperstimulation syndrome and intervention for OHSs with antagonists when it was compared with the agonist cycle. Nowadays, most of the people are with the antagonist cycle only. Agonist is probably reserved for very, very few non-responders. In case of antagonists with the ovarian hyperstimulation, of course, there is a reduced risk, but totally we can't say that we are now free of ovarian hyperstimulation. Large observational study found the ovarian hyperstimulation incidence in antagonist cycle is as good as 2.1%. At the same time, there is another observational studies found with the agonist cycle, the incidence is as close as 3.3%. So not a big difference between the two variety of the analogs to have the ovarian hyperstimulation syndrome. Can we use the trigger as a GnRH agonist instead of the HCG? Because we always understood that the HCG is the culprit for protection of the ovarian hyperstimulation syndrome. Yes, agonists will reduce the risk of ovarian hyperstimulation syndrome by shortening the duration of luteal stimulation, by lowering the estrogen level, by inducing luteolysis, and by reducing the secretion of VEGF. Agonists may directly reduce the activity of VEGF by stimulation of granular cell expressions and secretion of PEDF, that is known as the pigment epithelial derived factor. This study was first published in Journal of Clinical Endocrinology and Metabolism in 2015. This study found that there is an increased expression and secretion of PEDF in the response to bolus of agonist that may antagonize the adverse effect of VEGF on the ovarian vascular permeability and may contribute to luteolysis by reducing corpus luteum vascularity. And thereby, it can reduce the risk of ovarian hyperstimulation. In addition, the stimulation of PEDF may also be part of protective mechanism of dopamine agonists, which can be used for the prevention of hyperstimulation. Metformin is a very common drug used in the PCOS patient. Can metformin help us in reducing the ovarian hyperstimulation syndrome? Let's see. The insulin stimulates the PEGF expression and the secretions, and the insulin sensitivity is improved with the help of a metformin. So it has a role to play. There was a randomized controlled trial of a woman with a PCOS undergoing the IVF found to have a lower incidence of ovarian hyperstimulation syndrome in a group receiving the 850 milligram of metformin twice a day from the day of downregulation till the oocyte recovery. The systemic review of another 5 RCTs showed a benefit from the metformin as a co-treatment. Albumin can also be used for the late prevention of ovarian hyperstimulation syndrome, and it was found in the most of the studies that it favors the treatment in preventing the ovarian hyperstimulation, especially of the late onset. Dopamine agonist is another drug which we nowadays use a lot, considering it as a wonder drug to prevent the hyperstimulation syndrome. First of all, the Gomez et al. In 2006 has published a rat hyperstimulation syndrome model where he found that VEGF activation in ovarian hyperstimulation syndrome appears to be associated with reduced dopamine activity. Low-dose dopamine agonists can inhibit the VEGF-induced vascular permeability rise without affecting the angiogenesis. In randomized controlled trial in the oocyte donors with the more than 20 oocytes showed a reduced incidence of moderate but not severe hyperstimulation. The group treated with the cabergoline 0.5 mg daily from the oocyte recovery for 8 days. Cabergoline treated group had a lower incidence of ascites and a lower vascular permeability assessed by the dynamic contrast MR. There is another randomized controlled trial with another dopamine D2 receptor blocker, the agonist, secunaголide, showed the reduced incidence of moderate to severe early ovarian hyperstimulation syndrome when started 2 hours before the SCG and continued until the pregnancy test. Significant effect only seen with the 200 microgram daily without having the side effects. This study was published in 2010. Though the magnitude of benefit and whether dopamine agonists can prevent the late onset hyperstimulation syndrome is still not very clear. Can we use IV calcium gluconate to prevent the ovarian hyperstimulation syndrome? Because we all know the calcium gluconate infusion is as effective as the vascular endothelial growth factor antagonists like the cabergoline. So it can reduce the activities of all the markers, especially serotonin or the renin-angiotensin, especially in preventing the effusion of the fluid across the vascular channels. It can be used. The study, we have used 10 ml of the calcium gluconate, and it was found that in comparison to the control group, the ovarian hyperstimulation syndrome was found significantly low, and the pregnancy rate and delivery rate was significantly high. So it was found that the IV calcium gluconate can be used as an agent to prevent the ovarian hyperstimulation syndrome. Aspirin can help us in the prophylaxis for the ovarian hyperstimulation. Rationale is it prevents the platelet activation and the release of inflammatory mediators. There are a lot of inflammatory mediators. They are responsible for increasing increasing the permeability across the vascular channels. Aspirin is associated with the reduced incidence of severe to critical ovarian hyperstimulation in the long protocol agonist treated patient with those who are receiving the 100 mg per day from the day 1 of the cycle. However, the randomization validity and ovarian hyperstimulation assessment is not very clear. This study was published in 2010. Again, this was published in 2010, 9 and 10, and the fertility study. And still we are on the same platform, not very sure how much help can be. But there's no doubt about this, the late onset thromboembolic phenomena associated with the ovarian hyperstimulation syndrome can be reduced. Therefore, the introduction of low-dose aspirin therapy during the ovulation induction for the prevention of ovarian hyperstimulation, especially in a high-risk patient, should be considered. Cryopreservation of all embryos can also be very helpful. It can eliminate the risk of a late onset ovarian hyperstimulation, but early onset ovarian hyperstimulation syndrome can still occur. Patient may prefer this to the cycle cancellation. Considering especially if the patient is asymptomatic at the time of embryo transfer, one can delay up to the blastocyst culture. That may give more time to assess the patient ovaries. Continuation of agonist, especially in these patients, may reduce the risk of ovarian hyperstimulation by preventing the endogenous surge. Role of letrozole. Nowadays, all people are trying the letrozole in the luteal phase to prevent the severity of the ovarian hyperstimulation in the patients, those who are known to end up in hyperstimulation. Letrozole in the luteal phase decreases the serum estrogen level of patients after oocyte retrieval, but it couldn't reduce the risk of severe ovarian hyperstimulation. So we can have the moderate ovarian hyperstimulation syndrome can be under our control. Letrozole was more effective than aspirin in decreasing the incidence of moderate and severe early onset ovarian hyperstimulation syndrome than the late onset. This was a study published in the American Journal of Obstetrics and Gynecology in 2017. Laparoscopic ovarian drilling especially was very much in use, especially in the patients with the PCOS. And generally we assumed and found that it may help us in reducing the ovarian hyperstimulation syndrome. Especially it can help us in controlling the moderate or the mild variety of the ovarian hyperstimulation syndrome or the early onset of the ovarian hyperstimulation syndrome. This was supported by the most of the studies. So once we know that we can prevent or predict the ovarian hyperstimulation syndrome, but still there are the few patients landing into the ovarian hyperstimulation syndrome, how they should be managed. The other two varieties of the patient can be managed. One is outpatient management and another is the in-house management of the patients. For the outpatient management, it's very important to understand that we are dealing with the mild or moderate variety of ovarian hyperstimulation syndrome, and they are staying close by to the center and they can attend as and when required for the follow-up. Counseling is very important, especially about the fluid intake. Analgesics are needed and should be given. Report worsening should be taken care of, and we can expect the recovery in 7 to 10 days. Monitoring requires the daily phone call to these patients, especially the first assessment of the baseline level of the blood counts, urine examination, and the LFT, weight, abdominal girth, and then every second and third day, the follow-up can be checked, follow-up can be taken. About the outpatient management, yes, there are the few patients require admissions. That depends upon the sign, especially any sign of severe ovarian hyperstimulation or unable to control the pain or nausea, unable to eat or drink. There is a shortness of breath or oliguria. These are the signs which require the from outpatient management to the in-house management of these patients. So hospital admission, the indications are severe pain, unable to eat or drink, oliguria, shortness of breath, or any sign of severe ovarian hyperstimulation biochemically or clinically. Daily monitoring requires the weight, abdominal girth, intake and output chart, full blood count, hematocrit, urea and electrolytes, liver function test, plus routine observation for chest X-rays, ECG, abdominal and pelvic ultrasound, and coagulation screening. Inpatient care also include the pain relief because of ovarian stretching. There is a severe pain at times. Paracetamol or codeine can be used. No NSAID is required. Consider another cause of pain, especially in these patients. Never take it granted that it's only because of ovarian stretching. It can be because of ectopic pregnancy or the torsion of the large ovaries. Fluid management is very important. Not allow them to have overload. Allow as maximum as possible to drink to thirst. IV fluid only for initial rehydration or if unable to drink normally. Use albumin if the saline fails to correct the dehydration. Drainage of ascites and effusions is required, especially there is a severe distension causing distress or difficulty in breathing. Poor urine output despite the dehydration, prolonged course of a treatment, especially this should be done under the ultrasound guidance. Indwelling catheter can be considered when we are considering it as severe ovarian hyperstimulation syndrome with the massive collection of the fluid or very fast collection of the fluid, and albumin must be replaced because there is a severe hyperproteinemia. In patient care, we have to be careful about the prevention, especially for the prevention of the thrombosis. It can occur even after the apparent improvement, commonly affects the upper body, reported up to 20 weeks of the pregnancy, so one must be very careful. One may occur despite the prophylactic heparins are given. There is RCOG guideline that advise the low molecular heparin for all inpatient, especially if dehydration or reduced mobility. If the pregnant, then continue at least till the end of the first trimester. The feature of critical ovarian hyperstimulation syndrome should prompt the consideration of need for intensive care and the multidisciplinary assistance. Role of pelvic surgery at times because of the severe pain, we are restless what to do next. But the role of pelvic surgery is restricted mainly to the torsion, nothing else. Otherwise, is just touching a fire. There are the interventions that do not reduce the risk of ovarian hyperstimulation. That includes the intravenous albumin, follicular aspiration prior to SCG, recombinant LH instead of the SCG, recombinant SCG instead of urinary SCG, and one type of FSH versus another type. So the evidences are not in a favor, which can reduce the risk of ovarian hyperstimulation. So what are the key points in the clinical practice? Let's summarize. The cornerstone of successful prevention of OHS is accurate prediction. That is the most important. The previous history of ovarian hyperstimulation or PCOS syndrome is highly predictive of development of OHSS. SCD increases the VEGF production by granular cells and endothelial cells, which may result in increased vascular permeability and the hyperstimulation syndrome. The presence of large number of ventral follicles, increase in small and the intermediate follicle during the stimulation are associated with the increased risk. Increased intra-ovarian blood flow and the low intravascular ovarian resistance are correlated with the severity. The presence of multiple pregnancies is of course going to increase the risk of the ovarian hyperstimulation syndrome in both the terms severity and the duration. So what are the future directions? We require better dissemination of existing evidence-based knowledge, use of mild stimulation for IVF, single embryo transfer, in vitro maturation of sites, though at present we are facing the low birth rates. We require more RCTs of a dopamine agonist versus the posting. We require future selective EGF antagonists, waiting for them to be with us, and trial of early paracentesis versus the conservative approach. I think I've done the justification of prevention, prediction, and the management of ovarian hyperstimulation syndrome for all the concerned people. Thank you.
Thank you, sir. You have fully justified that time a lot to you, and I must say this was one of the finest presentation of our favorite 5, and we will definitely look forward to meeting you in future. And I am sure our attendees are enthralled with your presentation because there are so many compliments for this wonderful presentation. And few things that you said, sir, about the costing effect, we would like you to stay back for the questions because there are lots of questions from audience and questions from us also. Like the costing effect, we would like to discuss in the subsequent questions, what is the effect on equality. And like you talked about the FSH receptors, that was very important one information because some of the patients have that inherent sensitivity to FSH receptors, and that is towards the trophoblastic HCG. So neither the patient was for IVF, no the stimulation or trigger was at fault, but still patient develops OHSS, and this thing has to be kept in mind. You have touched all the aspects, the simplest and the finest. Thank you, sir. And I would like to invite Dr. Meenakshi for the most wonderful presentation. Must thank Dr. Sanjay Makwana. Over to you, Dr.
Thank you, Dr. Seema.
Yes, Dr. Meenakshi. Hello, Dr. Meenakshi is from my alma mater. She is the most humble and dedicated gynecologist from Nagpur. Dr. Meenakshi.
Ma'am, I think her networks got disconnected.
Okay, so we will be proceeding because Dr. Alok Sharma, I can see he's in car and he's going for an emergency. So I would request Dr. Bavishi, Dr. Makwana and Dr. Dipankar sir to stay for the important panel questions. And we have Dr. Harjinder Gogia. She's the Chapter Secretary of Punjab, and she's doing good work in infertility. And can we have questions, Dr. Deepika ji? Sir, we have certain questions for our panelists where we are doubtful and we want to take home a concrete evidence, and then we will take the questions from all our audience. So, IFS slide, can we have Deepika ji for this? Is it possible to display, or we can have in the end, Deepika ji? Okay, we will have in the end. Let's proceed with the questions, no problem. Sir, there was question for Dr. Himanshu. This is from Dr. Priya, that patient has hydrosalpinx and endometriosis. Do we need to clip? Okay, so this is a request to all our audience to attend and participate in the 16th annual conference Fertivision. This is first virtual global congress of Indian Fertility Society, and we have all national and international speakers. And on behalf of Indian Fertility Society, we request you all to please join. And this is at a very nominal amount. And these are the account details. This will be available on the YouTube channel of Deepika ji, so you can load it and apply. And we would like you to have much more knowledgeable sessions in this. So till you load the slides, Dr. Himanshu, this was the question that patient has got hydrosalpinx and endometriosis. So this is from Dr. Priya. Would you like clipping of the tubes?
It will depend on both the things are independent. So if you are doing surgery for endometriosis, yes, certainly you should do that. And you should treat hydrosalpinx as hydrosalpinx, because hydrosalpinx itself is a subject. You don't need to clip each and every hydrosalpinx. You don't need to clip. You can also remove the tube if you think that it is a bad hydrosalpinx which may get infected later. So it depends on the situation in the pelvis, that how good and comfortable you are in the surgery, whether you are actually doing surgery for endometriosis, or just because the patient has endometriosis and a hydrosalpinx, which may be a mild hydrosalpinx, you may not necessarily clip. But if you are doing a surgery, then of course it's a good idea to clip.
So won't it be that then when there is hydrosalpinx and endometriosis, it's likely to be the severe grade and not the mild or moderate? So it won't be feasible to clip the tubes, or will it be? Because we come across only the severe endometriosis, we have all these findings, and it becomes very difficult to clip the tubes. So won't it that we are taking into consideration only endometriosis and that helps us?
No, to best of my means, if I say my experience, clipping is the easiest thing, because you can reach to at least the cornal part of the tube and you definitely see the uterus. And so it's a good idea to clip, because it's a minimum thing or minimum invasive procedure which you can do.
Awesome.
Removing will require more time, expertise, and situation also should permit. So clipping is a good idea if you think that hydrosalpinx needs to be addressed.
Right, sir. We have Dipankar sir here, sir. Dipankar sir, will you differ from Dr. Bavishi or go with him, sir? Dipankar sir.
First of all, namaskar Himanshu and namaskar Sanjay.
Hi. Long time.
Long time. And second is that I don't dare to differ from Himanshu.
Okay.
So nice.
Sir, you can answer off screen if you differ. Okay, thank you. So we have first question to Dr. Harinder Oberoi. She is the director of Oberoi Hospital and IVF Center, Jalandhar, and our chapter secretary, Punjab IFS. Dr. Harinder, what are the reasons for poor pregnancy rate in endometriosis?
Yeah. First of all, I request, it's my proud privilege to be with all esteemed stalwarts and dignitaries. I am really thankful and grateful to Dr. Seema Mittal, who has invited me for this beautiful, excellent webinar series. Thanks to you and all my co-panelists. So coming to the questions, number one. So as you already know, as already described by Dr. Himanshu Bavishi in detail, just to summarize, it is endometriosis, it is an enigma and controversial entity still, and it is associated, there is a great association between endometriosis and infertility, and there are several mechanisms which are proposed for endometriosis and infertility. So as described by Dr. Bavishi, so there is in endometriosis, there is distorted pelvic anatomy and tubo-ovarian relationship is disturbed. So as in the from minimal to frozen pelvis, so there is a lot of adhesions, so that causes infertility, and thereby because of decreased egg release and defective egg and sperm transport. Now second is uterotubal transport is also altered because of it is decreased in the severe endometriosis. And next is there is altered peritoneal function because of there is endometriosis, increased peritoneal secretion in the pelvic cavity, which causes lot of adhesion, and this fluid contains lot of prostaglandins and interleukin 1, 6 and 8 and cytokines, VEGF, increased cytokines by macrophages, and all this causes adverse effects on egg, sperm, embryo and fallopian tubes.
Thank you, Dr.
Next is impaired implantation. So here there is more IgG, Ig antibody and lymphocyte. These are all increased in endometriosis and they causes decreased endometrium receptivity. And again there is next mechanism is by endocrinal and ovulation abnormalities. It causes luteinized unruptured follicle syndrome, and Because of decreased progesterone, it causes luteal phase defect and also premature LS surge, thereby causes infertility. And next is there will be defective embryo and oocyte quality because of altered hormonal imbalance and decreased progesterone level and more production of cytokines. As you know, if there is a patient of severe endometriosis, if we do oocyte donation in these patients of healthy donor, so there will be more pregnancy rate because of more endometrial receptivity. And there is altered immune response. All these mechanisms, they are responsible for poor pregnancy outcome in endometriosis.
Thank you, Dr. Harinder. I think sir has already talked that there can be problem at the level of ovary or the peritoneum or the endometrium, or it could be anywhere, and you have very rightly answered and explained it well. So we shift to second question. I think Dr. Alok. Dr. Alok, are you still in
I'm
the...
there.
Yes. So just
I'm there,
answer this
madam.
question. How do you make diagnosis of early endometriosis?
Like, as Dr. Bavishi already has enumerated that it is a dilemma and locally malignant disease, so it is very difficult to diagnose. But yes, with the history of the patient also you can diagnose, yes, these are the three triad of this thing, endometriosis, that is dysmenorrhea, dyspareunia and infertility. If these three are there, history can say yes, this patient has got endometriosis. Then we can go for ultrasonography. We can go for local pelvic examination. We can go, and then, but the gold standard for the diagnosis is laparoscopy. So after that laparoscopy, you can still go for, yes, you can see whether it is again grades. Then you can like which stage 1, 2, 3, 4. So we can see on laparoscopy also. So again, the gold standard is laparoscopy. Then what the question is of CA125. So CA125 is again not very sensitive test, but yes, it is increased in very normal conditions also. But a test can be seen, okay, if that is increased with all triad and laparoscopic findings, then I think CA125 is one of the important tests. Otherwise, CA125 is not so very sensitive for endometriosis, because again symptoms can be more in like early stage endometriosis and less in late stages of endometriosis. But yes, appearance also again it differs. So I can say these all are the things that we can see. Laparoscopy is the gold standard for the diagnosis of this endometriosis.
Thank you, Dr. Alok. I think you very well explained, and Dr. Bavishi had also taken it very nicely. So basically the symptoms and the ultrasound and the laparoscopy, because my question was pertaining to unmarried girls where we cannot go for laparoscopy, and ultrasound is not very helpful at times. So can I ask Dr. Makwana, is there anything that you can add which can help us to diagnose a young girl with endometriosis, sir? Dr.
I
Sanjay?
think we have to keep a very high at least very high suspicion for the pain. That is the only thing in the young girls, because you can't put the laparoscope in all adolescent or young child. If your pain is subsided by any other modalities like the simple analgesics or by the counseling or any other thing, or by taking care of GI symptoms, then definitely the left is the endometriotic pain, and accordingly one must treat it. Otherwise, we'll end up in the severe disease later on. So that is the only thing, because diagnostic modalities are not much. And as per the guidelines by the Indian societies and by the ASRM, the role of ultrasound is also restricted. You can't put all adolescent girl on the ultrasound. So we have to really use our clinical acumen to separate the pain of endometriosis from other pain.
So, sir, here my question is, another question is, can we give her diagnosis just based on the suspicion and our clinical diagnosis? Like yesterday, I had a girl who had such severe dysmenorrhea, and I could see some fluid in the, she was obviously married, I could see some fluid in the pelvic cavity and ovaries were approximate like with the uterus. And I thought maybe it could be endometriosis, but she had infertility also. So my questions are, one question is, should we start her on diagnosis or whatever, just based on the clinical diagnosis, number one. Number two, this is a question from one of our audience also, Dr. Vandana, that would her hormones be affected when we put her on diagnosis, just on empirical diagnosis?
Dr. Seema, I am very particular about using any medical management of endometriosis in the patient, those who are married and thinking about the pregnancy or desirous of pregnancy in the near future. Because somehow, with the use of Dynogest, you can reduce the inflammation and you can reduce the pain, but you can't check the disease progress. So if you can't check the disease or you can't diagnose with the confidence, definitely you are landing in a problem later on. So it should be very carefully planned medical management of endometriosis in the desirous patients. Unless you are very sure and you want to buy some time, then the patient must be put on the medical management. Otherwise, the definitive therapy must be taken up. I think Dr. Bavishi will agree to it. Dr. Himanshu, you can add something to it.
100% agree with you.
Right, sir. Dipankar, sir, any difference of opinion?
There is no difference of opinion. The thing is, the problem with the practitioner when patient comes to us, how do you understand this is stage 1 and stage 2? It is very difficult.
Right.
And laparoscopy is gold standard. When we do laparoscopy, then why should we do laparoscopy, number 1?
Right, sir.
Number 2, the girl you came to you with this symptom and all. If you take the history properly, there are 2 types of dysmenorrhea.
Yes, sir.
One is spasmodic dysmenorrhea, which is very common with the girls or with the female, that when they are passing the clot. So that is the biggest pain at the first day of period.
Right.
But when you take a history for infertility or a patient with a dysmenorrhea, if this dysmenorrhea starts from before the beginning of the period and it is staying with the period, then, and if she is presenting with unexplained infertility sort of thing, then we should have in mind that she might be having endometriosis, which might be mild variety, which is not visible in ultrasound. The dysmenorrhea, dyspareunia, and dyschinesia, these things happen in a late type of endometriosis. But the problem with us, when it is visible in ultrasound, everybody can diagnose it is endometriosis and chocolate cyst and whatever it is. The problem happens when you are going to treat the endometriosis and when you are going to ask that lady, finish your family fast, otherwise you will lose your ovarian reserve. The thing is, to diagnose the earliest endometriosis is the biggest problem with us. Then we do a laparoscopy, and with that laparoscopy, we can diagnose, that is a gold standard, that we can diagnose endometriosis. My point is, in my practice, when I do this infertility practice, when to diagnose there is a endometriosis or not, CA125 is not at all a good method. So it is the index of suspicion, taking a proper history and doing a good ultrasound. These things, most of the time, the endometriosis starts within the ovary as a chocolate cyst. Followed that cyst, if it is there and there is an increase in density, think about there might be an endometriosis, then take your decision whether they want to delay or they want to have a child.
Right, sir. Thank you, sir. And next question is to Dr. Bavishi, sir. How often do you come across cases of adenomyosis with endometriosis, sir?
How
Bavishi, sir?
often?
Yes, sir.
It's I would say that about 10% of the patients have more or less adenomyosis. Fortunately, severe adenomyosis is still not very common, but it is not uncommon as well. And it is the worst thing to treat severe adenomyosis even than severe endometriosis. Because to get a pregnancy and successful childbirth in a patient of severe adenomyosis is even more difficult than treating a severe endometriosis. Line of treatment necessarily may be same in the sense that early pregnancy is the gold standard so far as the patient is willing to have pregnancy. But so far as the symptomatic treatment only is concerned, then it is good that you do a destructive surgery and the patient gets relieved of the symptoms. But if she is not planning for pregnancy now and is planning for pregnancy in future and still is not means a good candidate for a destructive surgery, these are the cases even worst. So we need to counsel them, try to make them, same line, convince them that it is better for them to finish their family as early as possible. I personally do not like to excise adenomas because they are really not rewarding in my experience.
Very true.
Very rarely I have done it for a few patients where the symptoms were very unbearable and they were definite big size localized adenomas without very bad other part of the uterus getting affected and all. But still, I personally would not recommend that it's a good surgery. But that's the only situation.
So because the literature says that there is a very high incidence, somewhere they put it at 60% also with severe endometriosis. So sir, your take on this is that even if there is adenomyosis, we have to continue with the same treatment and they should finish childbearing as early as possible because it's a progressive disease and no treatment, even the surgical, that we also feel that that is the justified statement because by doing surgery, we are just spoiling the endometrium further and that is not of much benefit. So we take the message that we have to treat as we are treating endometriosis and go with the treatment as for infertility and as early as possible. Thank you, sir.
And even we should say, first of all, always keep in mind that the patients of endometriosis can have adenomyosis, so look for it.
Right.
And second thing, if you see adenomyosis, you even more carefully counsel the patient for early pregnancy than even endometriosis.
They are very bad. Like when we are treating, I feel they are never got like pregnant, like in our experience. So maybe people like you work more on it and we come to some conclusion because as far as we are not doing much of research work, but patient showing adenomyosis, we know that this patient will not conceive. So my next question is to Dr. Sanjay Makwana, sir. Medical, surgical or no treatment before proceeding to ART? Sanjay, sir?
In case of endometriosis?
Yes, sir. We've not come to HSS as yet. So because
I am very comfortable with not having any medical management of endometriosis before going for a ART cycle because it will not help me at all. The pregnancy is the better choice, so I'll rush for the pregnancy. As far as the medical management is concerned, in the grade 2, grade 3 endometriosis, it will just reduce some edema and will take away good amount of the time from me. So just reducing the edema and giving some pain relief to the patient for the time being and delaying the pregnancy will not help me. That is first thing. Second thing, of course, keeping a watch on the ovarian reserve is very important. And if it's really going on the lower side, then I'll be rushing for the ART procedure rather than going. As far as the JNRH analogs are concerned, all now we understand better that use before the surgery or before the procedure will not help us unless you have really difficulty in approaching the ovary through transvaginal sonography. Then and then the surgery has a role to play and one must use it. But the judicious use, as far as the secondary surgery or second surgery is considered, there is no role in endometriosis management, especially endometriomas. One has to go by the side of endometrioma rather than going inside the endometrioma and operating second time.
Right, sir. So take-home message for us is that if there is endometriosis, it is better to straight away proceed with the treatment of infertility and
Dr. Seema, one has to really justify the need, what the patient is looking for. If patient is looking for a pain relief, think about the pain first. If it's patient looking for the pregnancy, think about the pregnancy first. We can't have the tailor-made approach for all endometriotic patients. It should be justified as per their own need and our clinical parameters.
So most of the patients who come to us, they very well know that they have endometriosis and they need IVF. And so here we are talking about those patients, only those who have taken treatment from places and now they have come whatsoever, whether they have pain or whether they go for donor embryo or donor egg, but they just want pregnancy. Dr. Bavishi, sir, will you differ from Dr. Sanjay on this issue or we go with the next question?
As I said that, and he very rightly said, and anybody will agree to that, that first thing is that our target should be what the need of the patient is. So
Right.
if it is only pain, then of course it's totally different. But if it is fertility, then 100% what Sanjay said. But at the same time, what I have seen in my personal experience, that the patient are really confused about what is their priority. And it is very important for us to sensitize them and explain to them that, okay, you are thinking, because patient has a feeling that I'll be relieved of my pain, so I'll conceive naturally. Or once I just get rid of the pain, I'll try for some time and I'll conceive. So that is important for us to explain that, okay, we don't mind treating you for your pain and making you happy, but you should be careful that what your goal is, you should be clear in your mind.
Can I enter?
Yes, sir. Yes, sir. Most welcome, sir. Yes.
What I did in my clinical practice, that you have already said that there is adenomyosis. If you see and you understand that patient is not going to get pregnancy, what I did with a severe adenomyosis is, patient has an endometriosis also with adenomyosis gross. I did IVF and frozen all embryos. And then I put that patient to GnRH depot, analog depot for 3 months, 3 or 4 months. Then I did a frozen embryo transfer. And she delivered twins. So don't give up. The thing is, if you can manage the making of embryos of that patient, please do it, because if you don't do that, then she is going to lose her eggs also. So at least harvest those eggs and make embryos, and then you can do down regulation with 3-month wala depot or 1 month wala depot. Then you have a choice to do a frozen embryo transfer after making the endometrium. Even though this patient has very gross adenomyosis. So she had, I am giving my own practice what I did. She had 6 or 7 IVF failure because of this gross adenomyosis. I was also scared to do that, but I did because she had little ovarian reserve. So I did frozen the blastocyst, and after 4 months, I did embryo transfer and she conceived. So don't give up. Don't say that she might not get pregnancy. There might be. Collect those eggs, make embryos, and try to do a frozen embryo transfer.
Thank you, sir. So this was the most wonderful disclosure, but 2 questions that have come into my mind are, number 1, was she amenorrheic after 3 depot preparations? Number
Absolutely,
2,
absolutely.
for how long? And sir, what was the luteal phase support that you had given to that patient exactly?
I gave her, for just like HRT, it is 1 TDS estradiol, that is estrabet, 2 mg TDS.
Right,
I make it QID.
Okay.
And then after 5 days of progesterone, I give vaginal progesterone with intermittent alternate day intramuscular 100 mg intramuscular progesterone.
So this was after she menstruated. Did you give her anything to menstruate after that?
No.
Just straight away.
She got down regulated.
Right, sir.
And you can very well understand whether she is down regulated or not by E2 and LH.
Right, sir.
And after giving this amount of GnRH analog depot, you can very well make it by ultrasound also. Right. So it is not necessary that she should come with the periods. You can start as if she is in menopause. So it is like a frozen embryo transfer, and her uterus was little bit of lesser size after this analogs.
Right, sir.
But she behaved very well with preparation of this endometrium, and she had 7.5 or 6, I don't remember exactly, but because I did Caesar after 6 days or 7 days back. So she developed good endometrium, and she get pregnancy. That means my treatment was good. So, so it was okay. But what I counseled her, that even though you have failed a lot, but you can do an embryo cryopreservation and then do a frozen embryo transfer.
Thanks for the encouragement, sir. Thank you so much. And next question is to you only, sir. is it always the agonist trigger in endometriosis or no? So we are talking about OHSS and endometriosis both. So what should be the ideal trigger for endometriosis and what should be the ideal trigger for OHSS?
You're asking me?
Yes, sir. This question is to you.
The two things are totally different. So you cannot mix it together because endometriosis is always most of the time low AMH patients. My trigger is based on number of oocytes I am going to get and what is the amount of estradiol on the day before HCG. So even I do 15,000 HCG also.
Right.
That is separate from endometriosis, and who is going to have a hyperstimulated ovaries with more than 3,000 or 2,500 picogram of estradiol. I nowadays, even I think Sanjay and Himanshu will with me, that we are almost OHSS free clinic nowadays because we very well know from the beginning of the stimulation that this patient is going to behave in which way. So we decide as a personalized treatment for the patient, should we use GnRH agonist or antagonist? So most of the time with high AMH patient, we use antagonist, and my trigger is always with hyperstimulated with this type of patient is GnRH analog trigger. But GnRH analog trigger gives a poor pregnancy rate. So GnRH analog trigger is useful in those clinics mostly where the embryo cryopreservation is very good.
So, sir, you will go for agonist trigger only. My question to Dr. Sanjay. So, what will you recommend in OHSS cases the trigger?
I'm very clear about the use of a trigger. If there is a good response means we are going to get a more than 15 oocytes, or the E2 levels are more than 3,000, then I'll use the agonist trigger, because agonist trigger will force me to either have a freeze-all cycle, because otherwise the pregnancy rates are going to be low, or if the cycles are looking good and still I've gone with the agonist trigger, then I'll try to rescue the corpus luteum by adding the low dose of HCG. So if these two options are with me, then I'll think about the trigger. Otherwise, I had to think about how to proceed with the safety, avoiding the hyperstimulation. If the number of follicles are less than 15, there is no doubt I'll be going with the double trigger with the HCG and the agonist both, so that I have the good luteal phase support and I can have the better outcome of a pregnancy. But in case of a hyperstimulation and more than 3,000 E2 levels, definitely trigger should be the agonist. If you have the robust freezing program, then it is very good. Go for a freeze-all protocol and you'll enjoy the pregnancy outcome. Otherwise, try to rescue the corpus luteum whatever the way you want to.
Okay. So, and next question to Dr. Sanjay sir, to you only. For non-IVF cycles, the best ovulation induction is with latrose or clomiphene or choice of gonadotropin. If you look at both the situations, you answer according to OHSS, and Dr. Bavishi will answer for endometriosis patients.
For non-IVF cycle, the best ovulation induction is the patient based on the patient selection. If patient is coming for the first time to us and we have to start the ovulation induction is non-PCOS group of patients, definitely I don't want to leave the clomiphene citrate behind, because in the oral ovulation we have the limited drugs with us, so we should be very, very careful in using our material. In case of PCOS group of patients, there is no doubt now all the recommendation says the letrozole should be used as a first line therapy. I can start with the 2.5 milligram for the 5 days. If it is going well, patient is ovulating with it, it's okay. Otherwise, I can increase the dose. We can have the step up or step down protocol in the non-responder with the 5 milligram of letrozole for 5 days. Then we can have the 4, 3, 2, 1 or 1, 2, 3, 4 type of the stepping of letrozole. That will help in having the better recruitment of follicle with the better outcome of the cycle. Adding the gonadotropins to the letrozole, I am a bit careful, because I want just in the second phase of follicular stimulation, especially the HMG in the second phase, when already the follicle has crossed the 10 millimeter. Otherwise, in the early phase, I'll prefer still to have the clomiphene citrate with the FSH going in the early days, like second day or third day. Then the responses are much better.
Sir, what is the step up for letrozole? How do you give it?
Step-up protocol is based on the first day you, like second day or third day, you start with the 2.5 milligram one tablet, then second day there's a 5 milligram, third day is 7.5, and the fourth day is the total 10 milligrams. So total of the 8 or total of the 10 tablets we are using, 1, 2, 3 or 4 days the estimation will be over. That will, in the cases where you have the high number of the antral follicle count in the ultrasound, so you know that the initial recruitment is going to be high. What you need is a gradual building up your gonadotropin level so that you have the safety profile with you. In the case where you find that the poor cycle response in the previous treatment cycle, or the antral follicle count is not as high but is the poor responding PCOS patient, then try to have the higher recruitment of the follicles with the use of 4 tablets on the day 1, then the 3, then 2, and then 1. Even if required that the response is slower, then you can add the HMG at this stage, and you'll have a good outcome of your cycle.
Thank you, sir. Actually, we were not following. We either give 2.5 milligram or we make it 5 milligram for 5 days. We have never tried this protocol.
It all depends on the safety profile, how comfortable you are getting your response with the PCOS or the patient, those who are exposed to the previous treatment cycles.
Right, sir. I think next question we skip and we go to the next. This question we are skipping and we move on to the next question. This is to Dr. Harinder. What is the difference between early and late onset OHSS? Actually, Dr. Sanjay has described everything so well that we are not with many questions. So just for our audience and just to recapitulate, what is the difference between early and late onset OHSS? Dr. Harinder.
I already dealt by Dr. Sanjay Makwana very well. But just to repeat the things, it is early onset mostly occurs before 9 days and late onset that occurs in 12 to 17 days after SCG trigger. So it is iatrogenic condition and early onset mostly occur that is developed by the exogenous SCG, and the late onset mostly occurs by the endogenous SCG, mostly when the patient conceives. So here the male culprit is increased BEGF, which causes OHSS and fluid collection in the third space. And symptoms of early onset is comparatively less severe, and sometimes it is self-limiting. And here the estradiol level is more compared to the late onset. And early onset causes more preclinical miscarriages, and but in the late onset the symptoms are more severe and the condition is more serious, and there is more chances of increased multiple pregnancy in the late and the more severe cases in the late onset of OHSS. So we need more admission, more days of admission in late onset of OHSS, and sometimes we have to end up in the termination of pregnancy if it doesn't cure. So all these things are because of increased mutation and sensitivity of FSH receptors. So this is all.
Thank you, ma'am. And I think we skip the next question because there are some beautiful questions from audience also which we would like to take. So we are skipping this question, and next question is, how does costing help reduce incidence of OHSS? This question is to Dr. Sanjay. Dr. Sanjay sir, we want to just modify this question. You talked about costing to prevent OHSS, but we have seen that the egg quality is not so good when we do costing. So what is your take on this question? Dr. Sanjay Makwana, sir.
For the costing, one has to be very careful. You can't go on doing the costing for a long. As I said in my presentations, if it is more than 3 or 4 days, then definitely cycle is going to be poor outcome cycle. It's better to cancel the cycle. So you have to be careful when you are starting the costing. If you are starting too early, then definitely you'll end up with more days with the free when you are not giving any gonadotropins. And the oocyte quality, especially of the larger follicle, will deteriorate. So what we are looking for is the medium and the small follicle should not grow. And for that, we are withholding the gonadotropins. But the larger follicle of more than 15 or 16 millimeters, they are already in the number, you can say more than 10 or 12. Then the costing is fruitful to us. Otherwise, the oocyte quality will deteriorate and we'll have the poor outcome.
Right, sir. So we will go to the treatment part. So next question, happen independent. This question we skip and we go to next question, and this question is to Dr. Dipankar sir. Role of corticosteroids or aspirin in preventing OHSS. Dipankar sir.
No experience.
Dr. Bavishi sir.
No, I don't believe in this.
And Dr. Sanjay sir.
I'm using both the agents, steroid as well as the aspirin, in the prevention of the hyperstimulation. Once I am knowing that this patient may end up into the hyperstimulation syndrome because of the E2 levels or because of the, so first prevention already we have did with the agonist trigger. I still want to be sure, then the steroid or aspirin both help in reducing the VEGF secretions, or you can the sensitivity, so therefore the permeability will reduce. And that acts through the mast cells also, or rather you can say the inflammatory marker like IL-6 or IL-8, or you can say serotonin. They'll be reduced in number, and so therefore the permeability of the vascular compartment will reduce. This is what we are looking for. If you can reduce the permeability, definitely we are going to prevent the severity of the hyperstimulation. Though the data are not very much in the favor to reduce the severe hyperstimulation syndrome, but they are in the favor of mild to moderate hyperstimulation syndrome can pass very easily without any further complications.
Actually, you're right.
Clinically, we have a very simple clinical criteria, which we call as Bavishi BFI criteria, which are very easy to follow in clinical practice as well. Whether to do embryo transfer or not to do embryo transfer in patients. Ovary volume, 2 ovary combined 200 ml is the limit. Yes. Then is the free fluid. Free fluid 1, 2, 3, 4 up to isthmus, up to fundus, just above and entire above. So it is 1, 2, 3, 4 plus. Then E2 level 3000, hematocrit 42 or plus 4 from the baseline, and symptoms only mild. If the patient is fitting into this criteria, since 20 years we are following this criteria and we have not seen a single case of severe OHSS, even in agonist protocol or in antagonist protocol. And so far as the trigger is concerned, Sanjay has said very nicely, but I would say in very simple word, if you want a powerful trigger, when you really want a trigger to act, it's only HCG. Yes. If you want a safe trigger, then of course it's agonist. So depending on the situation, we need to decide. And if you want to be safe or play safe on those situations, agonist is better. But of course, one very important point, agonist can be used only in an antagonist cycle, not in a downregulation cycle.
And sir, to be honest with you all, because we feel HCG trigger is the best trigger, and when we are going to freeze in any case, then why not take chance with HCG and have good eggs and then good embryos. So the important take on
Bavishi, the same way we are following Dr. Bavishi, only thing we added is the abdominal girth. If there is a significant change, you can say 1.5 centimeter or more change in next 3 days, like from the day of pickup to the day 3, then we'll try to avoid the transfer in these patients. Otherwise, clinically, if the abdominal girth is not rising and other parameters, as you have said very perfectly, we can follow the transfer also.
Right. Thank you, sir. And the next question is role of calcium in OHS prevention, because this is something that we do for our patient. The moment we see their follicles and the moment we see the fluid, and we start on calcium gluconate drip for 3 days and we can sleep comfortably. So I just want to know from my experts that what is their opinion about the role of calcium in prevention. We start with you, Dr. Sanjay, and we proceed to Dr. Dipankar and
Frankly speaking, I have used in very few patients the calcium gluconate. The protocol which we are following, as Dr. Himanshu said, we are very particular about our protocol. And touch wood, we have not seen a severe hyperstimulation syndrome in the last 25 years in my setup. So one has to be really very, very careful in planning the cycle and the intervention which you want to put in, like use of trigger, use of the post-trigger treatment, monitoring, especially very intense monitoring of the patients, and using the drug very judiciously. Definitely, you can reduce the unnecessary intervention to the patients. Calcium, of course, plays a very important role. It can be used for 3 days in early onset hyperstimulation syndrome. It has no role in the late onset hyperstimulation syndrome, should not be used. So in the first 3 days you want to use, you can use the 10 ml and the 200 ml of normal saline, can be given for the 2 hours. And if we are going for 3 days, definitely along with the aspirin, or you can add the letrozole to it. You'll have really a comfortable time.
Right, so because calcium is good and capgulin and other drugs are also good, we have questions from attendees which we will be taking up regarding this. This last question from our series is to Dr. Dipankar sir. What is the future of kisspeptin as a trigger, sir? Dipankar sir.
Kisspeptin will come in our practice, but I am reading it since 4 or 5 years. Still not in market. I don't know. Himanshu might be knowing or Sanjay might be knowing, but I didn't get it still. But if kisspeptin is there, then kisspeptin is one of the method we can use in place of GnRS trigger, and it will give a natural sort of FSH and LH. But definitely it is a little bit higher way of triggering the final maturation. One thing I want to, when you are talking about OHSS, Seema, there are two types of doctors we are talking about OHSS. One is doing IVF and one is doing IUI, not IVF.
Very right, sir. Yes, sir.
They think OHSS is little bit easier to handle for person doing IVF. But OHSS is difficult for the person doing IUI, because when you aspirate, the chances of OHSS little bit goes on, and try to aspirate all the follicle. Second thing which I got in my practice, thoda bahut OHSS is good for pregnancy.
Yes, they conceive, sir. All of them conceive.
Yes. So if you can handle that mild amount of OHSS, then please handle it. Your patient is going to get a pregnancy most of the time, because HCG gives a very good VEGF response and it gives a good endometrium, but it is not a blanket statement. But the thing is, when the person is not doing IVF, for them OHSS is dreaded thing. So try to control the ovarian stimulation. Don't use too much gonadotropin without monitoring properly. The thing is, if you are doing IVF, the things are different. This is my point of the thing which I want to put in front of the August audience.
Right, sir. So agreed with you. So there is a question from Dr. Shashi Rekha Kumaran. This I think all three of you can answer. Maybe we start with the Pakistan only. Will the step up estrogen aggravate endometriosis?
I don't understand the question.
Will the step up estrogen, like you're giving estrogen and you're increasing the dose maybe for the will it aggravate endometriosis?
No, we usually don't give estrogen alone. Never. The estrogen and progesterone combined pill. The progesterone is the main part, because endometriosis is estrogenic environment. It is pro-estrogenic. So if you give only estrogen, the things will be, it is not a method of treatment. We should give better progesterone with estrogen or only progesterone, and the most least expensive therapy is medroxyprogesterone acetate.
Himanshu sir. Dr. Himanshu sir.
Yes.
I think you would like to add in this question, will the step up estrogen aggravate endometriosis? This is from Dr. Shashi Rekha Kumaran.
Now, this is basically being debated, and this is mainly debated to discourage the use of oral contraceptive pills for the treatment of endometriosis, which was a very cheap option for the treatment of the patients, and even long-term option as well. There is no reason to believe, because it is very low dose, even if you step up the dose and control the disease for a long time. So to me, I am not worried about that part, if that is the question.
Right, sir. I think we are done with the questions. So just summarize the, I will request Dr. Himanshu sir to just summarize 1, 2, 3, 4 points for the attendees, that in case of endometriosis, what they should do, because we have all those who are doing IVF also and those who are not doing IVF. So just in 2 minutes, sir, you can elaborate the take-home messages, and same from Dr. Sanjay sir, I would request.
First of all, an important take-home message. It's very nice and enjoyable meeting today. And the thing is that no patients give her lifetime to you for the treatment. So if you have made some plans for the patient that I will do the treatment for 3 months like this, then 3 months like this, then 3 months like that, then 3 months, patient will not come to you. It is not your life you are planning the treatment of the patient. If you are planning like that, it is important for you to discuss with the patient that, look, I am planning for you for 2 years, that first 3 months, 6 months I'll do that, then after 6 months I'll do this, and then after 6 months, most of the time patient will say, doctor, I'm not coming to you for 2 years. And same thing applies to one question which was asked, that what ovulogen you will use, what this. Same way, patients normally, if you take your own history, if you find out from your records, patients of infertility, even for fertility centers, only come to us for treatment for 3 months, maybe 4 months, maybe one IVF cycle. And patients doing second cycle, if they do not succeed in the first cycle, is as low as 30 to 40%. So what is important for us, all of us, to understand is that the primary counseling of the patient has to be very good, not only about the disease, but about the course of action which you are planning for the patient, and have a consensus with the patient that, okay, see, these are the things, these are the positive things, negative things, advantages, disadvantages, everything. But what is your belief and what is your desire? Because it is very important that you consider the patient's desire as one of the most important deciding factor in fertility treatment planning. It is not a disease. If the patient doesn't want child, you don't have to do anything. It's her desire that she wants, and it is her desire whether she wants 1 or 2 or 3, whether she wants in 1 year or whether she wants after 5 years. So unless we take into consideration all these aspects very well, discuss with the patient, what will happen is that you have beautiful plans for the patient, but patient will change the concept. And patient will say that doctor did not guide me proper, and the another doctor guided me proper, that, oh, you wasted 3 months, you should have gone for IVF. Something like that. So that is something which is the most important take-home message, because the rest of the things are discussed in detail.
Thank you, sir. And over to you, Sanjay, sir.
It was really excellent webinar. Enjoyed a lot of interaction, and it was really your warmth, especially of your society, is very nice. Enjoyed every moment of it. Interacting with Dr. Himanshu Bavishi and seeing after a long Dr. Dipankar is really extra treat in this webinar. And for the ovarian hyperstimulation, I'll say it is a part and parcel of the ovarian stimulation protocol. So don't be afraid of it. Only thing is, try to see or predict the patient beforehand. Don't go with the tailor-made approach for all patients. Try to justify your stimulation. Don't put all drug or whatever the drug you have in your hand on all patients. Be careful in selecting the patients, selecting the protocol, monitor yourself only, and be careful when the parameters are going out of your hand. This is the time when you have to take the action. Of course, the use of a trigger is very, very important, because we need a pregnancy. It's not only the stimulating the patient and leaving them for the hyperstimulation. It's better to get a good pregnancy outcome. Before starting the ART cycle, you must have with you the robust or a strong freezing program. If you are sure about your freezing program, you can take all variety of the patients. Otherwise, please don't jump on the ART program and put the patient at risk. Thank you.
Thank you, sir. This was the most wonderful presentation from Dr. Himanshu and Dr. Sanjay, sir. And this was, for me, it was like a dream come true, because when it's a conference, we don't get to interact one-to-one. And it's like, it's an added bonus that we have met you, and we will definitely look forward to meeting you again. And Dipankar, sir, we have found a wonderful teacher, actually. And
Sanjay, मैं तीसरी बार आ रहा हूँ इसमें.
Sir, we have 7 days, 7 scholars.
Dipankar is basically had a lot of things to teach to most of us, especially when it comes to genetics and the ICSI and all.
IBM also, sir.
I know very well him. So it's wonderful to have Dipankar every time, I think, in all the webinars. And he's
Master of all.
Thank you very much. Thank you very much, Sanjay.
So Dipankar, sir, any message for the audience?
Seema, I already given a lot of messages. So
thank you, sir. It was indeed a wonderful evening, and we look forward to many more meetings.
And I again give you a compliment that This is a great effort. I message you also. This is a great effort that she is making, and it is not an easy thing. Every week she is making a good conference with webinar. Hats off to you.
Thank you, sir. Thank you, my esteemed seniors, Dr. Dipankar sir, Dr. Makwana sir, and Dr. Bavishi, and my esteemed chairpersons, Dr. Uma, Dr. Rima, Dr. Meenakshi, and my wonderful panelists, Dr. Alok, Dr. Harinder, and team Jackson Pal for making this dream come true every week for us. And last we will be having next Tuesday, and by that we will be just finishing this series where we had for 7 days 7 scholars. We started with the basics of infertility, and then we moved on, and we had our 2 favorite speakers today, and it was a very good day. Thank you everybody, and do join ISAR. And over to Deepika ji.
Before that, the Deepika take over the mic. On behalf of the faculty, I should say that Jackson Pal is doing wonderful job, and Dr. Deepika, absolutely wonderful webinar.
Agreed.
Kudos to you and your team.
Yes.
Thank you so much, sir.
We should give a big thank to Deepika. Yes, very good, very good.
Thank you so much, sir. This on behalf of Jackson Pal, makers of Endorec tablet containing Dynagest 2 mg for medical management of endometriosis. Then we have our long-acting GnRH agonist, leuprolide acetate 3.75 mg injection, gonadoreg with technical advantage. The microsphere technology increases the stability so that no cold chain storage is required. Also, Lycored Preg sachet with L-arginine, DHA, and lycopene to avoid pregnancy complications. So I'm Dr. Deepika along with my teammates, thanking all the experts for sharing such vast knowledge with us today. We are truly appreciative of the presence of all the attendees and hope to go a long way in knowledge sharing with your unending support. We look forward to your presence in our next webinar, which is going to be tomorrow, and hope to see you all. Thank you very much.
Thank you.
Thank you, sir. Thank you.
Thank you so much.